Welcome, Dr. Alan Wong. We're really, really pleased to be able to get him here. He is the past president of the American Academy of Developmental Medicine and Dentistry, and professor emeritus, University of Pacific, as you heard, is an amazing dental school for people with developmental disabilities. So thank you for coming.
Thank you for hosting such a great conference. I've learned so much today. Isn't that a great conference? So it's a privilege to be here. I came all the way from Nashville to come. Yay! We go on these journeys and we never know what we're going to find out. When I first started out and went to dental school, I thought, I'm just going to be a dentist, right? But life takes different pathways. And things have to have happened and doors knock and you have to either open them or not open them. And it's been a great journey for me. So no financial disclosures to discuss about anything. I'm going to share with you some information about what's up and coming in oral health for our populations. Tell you a little bit about dentistry, where we are now and where we're going to go. A little bit about research. Let's see, my journey is from kind of recovery to discovery. I usually start out by saying, I'm a recovering restorative dentist. And meaning that the problem with healthcare is we don't focus on the health, we focus on the aftermath of health. I used to look at things of what can I fill? What do I need to pull? How can I do surgery? And the thing is, we've never stopped to say, how can I prevent the surgery? How can I prevent the hole? And how I can do different things. So I'm prevention focused and I call it minimally invasive in dentistry. I sort of entered into this field by mistake, but a good mistake. Like before this morning, they mentioned that medicine and dentistry doesn't teach this topic at all. You have to go away to get it, right? Which is a shame. And a lot of the information I learned is in my residency year, but more from my patients, my residents, my students, the parents, the direct support professionals, and you're the teachers of me, and I've got all this information together to share with my future colleagues as an educator. I just retired emeritus of 37 years of teaching, and the only reason I'm retired is because there are barriers for me to make an improvement in the healthcare system. I'm going to share with you that in just a bit. In my journey, I volunteered a lot. Someone got me a license plate that says, stop me before I volunteer again. And Special Olympics was something that was a passion for me to volunteer for. And I was asked to help to do that. And it did a couple of things. It opened my eyes further. I became a Special Smile coordinator or a project for Northern California and then the United States and worldwide. So I went through screening and training different dentists how to take care of people with intellectual developmental disabilities. And the problem is not just here, it's everywhere. It's everywhere. It's a lack of knowledge, a lack of understanding. And the goal for me was to sort of share with the message that it's not difficult if you just open your heart. Because when you touch the heart, you change the mind. And that's the problem. A lot of people, because we never had that experience in dental school, medical school, didactically, maybe we had some classes in it, but we never had the clinical experience. So we have a lot of clinicians afraid of taking care of patients with intellectual disabilities, Down syndrome, cerebral palsy. So we have to reimagine certain things. So as an operator, a dentist operator, I ended up having to think, how can we do things better? How can we invent ourselves to be better? And forced me to be an advocate. So my beginnings, my journey, it was really the road of less traveled. A lot of my colleagues don't take care of this population for different reasons. So there are barriers to the operators. But I've been teaching this for 37 years. Dental students want to take care of this population. I guarantee it. The problem is a lot of senior dentists are afraid. It's not always economic, but it's partly economic. But we've got to change the system. I did a lot of training. I'm not going to go through all my slides, but this is my semi-credentials. And you have the slide set with you. And when you seek to learn more about things, you learn more, and unfortunately, you discover things that are unimaginable. So in my life after retiring, because the postdoctoral program I was teaching, both in the clinic and the hospital, taking care of people under general anesthesia, that is not the solution. That's a treatment alternative because we failed in the prevention cycle. So I, in my mind, want to focus on prevention, but there are barriers to what I'm doing, and I had to go somewhere else, unfortunately, to do this. So I'm now at the Kramer Davis clinic that's in Nashville, Tennessee. It's a transdisciplinary clinic. And what that means is every day I go in, it's an adult care clinic only for people with IDD. So I work with developmental medicine, psychiatry, OT, PT, speech language pathology, behaviorist, and dental team. And the one patient comes in one, and we all take care of that person. That's true health. I imagine that. And we talk about the behaviorist works with us, so we don't have to take someone to the operating room. The way I say it is, I treat the patient, and then I treat the teeth. And we allow them to succeed incrementally, and it's a great system. So I'm hoping to collect enough data to show that we are going to save money doing it this way than the old traditional siloed method, where unfortunately you have to take your child to 10 different offices to share with them 10 different stories. And that poor patient has got to suffer with all these different changes. But anyway, that's how my journey is. That's where I am now, and I'm excited to be here. And I'm hoping that we can change the healthcare system for our friends and go forward. All right, so now we're going to talk about a little dentistry. A lot of things about the common physical signs. We're just going to go through this briefly because it's going to be in your handout anyway. Some of the challenges that we have to help overcome: the decreased muscle tone at birth, the atlantoaxial instability, that's where the neck joint is. A lot of times, dentists say, okay, lean your head back, and we sort of wrench your head back. That's dangerous. A lot of dentists don't know that, but we have to remind them. They have short hands, fingers. Sometimes dexterity is very difficult. And this is where I need your help, Dr. Heller, in research. For your mouse things, how do you get them to hold the floss? Okay, but seriously, there's a lot of research that has been left out in this population because it's a protected class. But we need to work more about doing strategically. And I'm so inspired by some of the research that I've heard here, and I've got some great ideas. So the mouth is where we're really concerned about, and some of those are the barriers that we have. Every person is an individual. Not one shoe fits everyone. Everyone has to have different modifications sometimes. So here are some of the health challenges of those for the medical condition. And the way these slides are meant out were supposed to be, I wasn't sure if I'm going to speak to all parents or some clinicians, so I have a little bit of both. So there's two columns, there's about 6 or 8 healthcare challenges, and what I would recommend for the clinicians in doing so. So I want to leave enough time for questions, so by your permission, I'm going to have the slides up there, highlight a few things, and kind of move forward. With intellectual disability, there's a spectrum, and some very high functioning, some lesser, and then we have to customize our information in a way that's understood. And I'm going to share with you how we're going to do that. We're going to prepare everyone for success, because I believe, just like your last talk in terms of the charter schools, we have to create a way for success in terms of education. Not one story fits all, not everyone flosses, not everyone brushes a certain way. And then we have to add in sensory. What is the best tool for that? For behavior management, a lot of times our patients, this is a new sort of environment, and the mouth is a very private area. So we have to treat it such. We have to get people comfortable with it. We call it desensitization or progressive experiences. And we have to figure out what works for them. It might be the taste of the toothpaste. It might be the touch of the toothpaste. It might be either an electric toothbrush or a sonic toothbrush or a battery toothbrush. What works best for them that they want to do? And I'll show you some of the tools that we have worked with. Bless you, someone. Sort of a step-by-step education. We have to also consider in that behavior management, some patients are going to require a little bit more than just tell, show, do in a more urgent situation. We might have to use some immobilization technique. And sometimes that is thought of as a bad thing. But done in a loving manner, it's no different than sort of hugging someone and swaddling someone. We hug and swaddle people because we love them. We're not trying to penalize them. We're not trying to scold them, but they have to understand what we do and why we do it. So before we have a knee-jerk reaction saying, no, we can't use that, we have to say why. Why do we need to do it? A lot of my patients with cerebral palsy, they enjoy it because it helps calm them, just like a weighted blanket might. So not everything should be thrown out. But again, we have to be careful how much we medicate patients too. We don't want to oversedate patients. And sometimes that's what I'm saying. General anesthesia is overused and overthought. And some patients think that, or parents think that general anesthesia is a more kinder way, but actually general anesthesia is chemical mobilization. But also general anesthesia has some effects to the brain as well and brain development. So we want to caution ourselves. Are we doing the right thing in a long term? Or is it really necessary? Now, if you have abscessed teeth and you have to do a lot of things right away, then maybe it's more urgent. You have to consider that. But through prevention, there's a lot of things now that are kind of nice. We have medicines that can stop cavities from growing. And we're going to talk about that in a couple of slides. All right, so anxiolytics. But the behaviorist, the board-certified behavioral person is amazing. And I believe, if I'm not mistaken, that regional centers also pay for that. So if you employ or collaborate with someone, a behaviorist with a dental team member or a behaviorist with another healthcare team member, to teach them how can we best handle the behaviors, they are experts in it. And we've utilized that in our clinic a lot. And it works very, very well. And the goal is to see a smile on that patient's face when they walk out of the chair, that they succeeded. Whether we took 3 x-rays a day or we took all the x-rays a day, it's okay with me. We have to set them up for success because success begets more success. So taking incremental things. Cardiac conditions, you've heard about it. Our patient population tends to have a little more cardiac concerns. We have to be mindful that we get the proper clearances. And some things that don't look right, don't sound right, we have to be listening for it. There's a term called diagnostic overshadowing. And that is attributing an underlying problem because of something else. And a lot of times, clinicians who are not trained to look for things miss things or just attribute that as part of the Down syndrome. A lot of times behaviors, some patients might have behaviors, they start hitting themselves, self-injurious behaviors, they start biting or grabbing things, and then later on you find out they had an abscessed tooth. Later on you find out they have impaction or they're having a problem with their stomach. And so instead of treating the etiology, they end up getting more medications, and those medications can make things worse. And then the behavior increases. So things like that. Our population has a compromised immune system that directly deals with our oral health. Not so much in cavities, but gum disease. Because of their immune system, they are more prone to periodontal disease. So keeping the teeth clean is very, very important. Not that they have tartar, but they sort of contribute to the inflammatory response of the whole system. And periodontal disease is not associated with cardiovascular disease, but it's not causative of it, but it it is associative. So when you have more periodontal disease, the likely more inflammation in your body, more likely that you have other problems. Diabetes is worsened, heart disease is worsened. So oral health has a systemic connection, whether you have a Downs or whether you have IDD or whether you're neurotypical. It's the same thing. Inflammation is inflammation. So not being able to be seen by a dentist is an important thing. So we know access to care for everyone is a challenge, but it needs to happen. We need to find someone. So hypotonia, it may further complicate situations in terms. It can create different things in terms of balance, how their musculature is, how they growth and development. We talked last time about sleep apnea and the growth and development of the jaw. That can happen. Their tongue can be affected. The muscle of expression, swallowing, drooling occur. And just because they drool, it means they have saliva. But the question is the saliva healthy saliva, or is it working the way it's supposed to? The number one thing about cavities, when I get to it, is the importance of healthy saliva. We're going to come back to that in just a bit. Seizures, they can be controlled with anticonvulsants, but the side effects of anticonvulsants and a lot of medications that medicine prescribes causes a change in the saliva's function, as well as rinsing off the acid in the mouth. Hearing loss and impairment, visual impairments, same thing. If you can't hear instructions, it helps you with communication. If you can't see what you're doing, it's hard to brush and floss properly. A lot of things go into that. So we talked about periodontal disease a little bit ago. You have this on your slide deck handouts. I believe Jessamine's going to provide for you. I know it's a lot to read after a large lunch. It was a great lunch. And I don't want to hear snoring, so I'm not going to read through the whole thing. But basically, periodontal disease is more prevalent in it. Prevention is so much more important. So even though your insurance may cover twice a year cleanings, a population that has a higher risk may need to be seen more frequently. So it's a risk-based care, not insurance-based care, unfortunately. And we've got to change the system in insurance. And some insurances are starting to understand that. I'm very proud to say that we have one insurance that we can clean them as often as we need to, and not because it's limited by 2 cleanings a year. So risk-based is very important, making sure that they have the dexterity, making sure that the patient understands what they're doing, why they're doing. Bruxism is grinding of teeth. Sometimes that's because of emotion, sometimes because of the medications we give them, and sometimes it's something that's bothering their jaw of some sort. They have a malocclusion. Maybe their teeth don't come together. So we have to take care of these things. Otherwise, teeth will loosen and can be bad. Developmentally, their teeth sometimes are more conically shaped, and sometimes they're shorter en root, so they're more prone to things. So injuries are very important to avoid. So mouth guards could be necessary, not all. And then again, the abnormal host response from the periodontium is important in terms of periodontal disease. In terms of cavities, those with higher caries rate or caries risk are those with bad saliva, basically, that don't protect their teeth as well. Often they're mouth breathers, and sometimes that dries their mouth. But is the saliva acidic or is it basic? If it's acidic, you're more likely to have cavities. If it's more basic, it's more likely to protect teeth, but you'll have more tartar buildup. So you have kind of duality here. That's why you have to be seen more frequently. But you can't treat what you don't diagnose. So it's important that in our new way of dentistry is we start looking at the etiological factors, and we're going to get into a picture that shows you more about that. Identifying the cavity risk and the gum risk and then treating them appropriately is prevention. That's what we have to do, and we can't say insurance won't pay for it thing, because it's more expensive not to. Malocclusion, we talked about that. That's how the bite is. But in terms of tooth anomalies, you can get many missing teeth or partially missing teeth called oligodontia. That's okay. That's part of the development. That's understand. You might find delayed eruptions, irregular tooth formations we talked about. And if you get those x-rays done earlier, the importance of getting the x-rays earlier, you can sort of find out what's going on if you have enough space, don't have enough spaces. But you might also have other x-rays as well. They have cone beams that can measure airway. So that helps contribute to the diagnosis of sleep apnea as well, where they measure their trachea, the windpipe, to see if there is enough area for the volume. And again, trauma and injury, we want to avoid that. So the hearing and the visual, sometimes you can't see certain things. And we have found worldwide that a lot of people are not wearing the right glasses or not wearing glasses at all. We find out that 50% have hearing, earwax impaction, and that can set you up for trauma, falling, and different things as well. And the sad thing about a lot of times, also this population is more prone to abuse. I think 7 times more likely for sexual abuse, unfortunately. But we have to be conscientious of watching and looking and making sure there's no strange bruises or bite marks or anything of that nature. Okay, so the paradigm shift is this. We talked about risk reduction. What is the reason for something to happen? And the new sciences. So the new sciences is SDF, silver diamine fluoride. It's amazing because it's cheap and it's very effective. What is it? If I saw a cavity and I painted silver diamine fluoride on it, the silver kills the bacteria and re-hardens the tooth structure. So that 2 things can happen. That when I go back in and drill it and put a filling in it, I don't have to drill as much. 1. 2, it desensitizes the tooth. Many a times I'm able to do a filling without having to numb up the patient, which is also a great benefit. So this is not just for our Down syndrome, it's for anyone to know. Now there are some parameters with this. The filling can't be super deep into the nerve, but if it's superficial, why not? It's been a great boon for me because I've been using it to desensitize a lot of our patients. Sometimes they have 5 or 6 cavities, but they can't come in for a long time. I can stop all the cavities from growing, so that by the time they get to me, I can take care of them safely. I call it putting out the fires. Because if you have 5 fires going on and you're only addressing 1 fire, the other 4 fires are getting really bad. So that's a new tool. The caries risk protocol, which I'm going to show you in a little bit, helps guide us on what to do, when to do it. Not when insurance says to do it, but clinically, why? ATP monitoring, that's one of the newer things that we use. We're testing for the activity of the bacteria. So I'll show you that in just a bit. Saliva testing, that's something that's kind of newer too. Testing the saliva, the resting saliva for the pH, whether your mouth right now is acidic or basic is important. Because if it's basic, you're good, but if it's acidic, your teeth are getting soft. pH of 7, if you remember chemistry, is neutral, right? The hardest thing in your mouth is enamel. That will dissolve at a pH of 5.5. The next hardest thing is dentin. Dentin dissolves at 6.2 or demineralizes. So when we drink coffee, it's like pH of 2, maybe even 1 even. Or when we drink something that's orange juice, might have pH of 2 or 3, right? Normally, our saliva works and buffers it and neutralizes it. And hopefully within 30 minutes, everything's neutral. But when our saliva glands are impaired either through medication or that our saliva is just impaired, period, it could stay at a 5.5 or 6 for all day. And if it's doing that, the teeth are softening, right? That makes sense? Simple chemistry. All right. So this reminds me of the risk factors. The risk factors in different age categories changes, right? That makes sense? But as we age, our saliva function decreases, and the production decreases, and you wonder why all the crowns I put in 20 years ago, all of a sudden I have to rechange them because all these cavities are growing. It's because the biology has changed. The protective factors that we once had that was really good have not gotten as good. And we're taking more medication for hypertension or for whatever you do. But anyway, it's not just about, products. It's not about just certain medicines or whatever. And it's not all about fluoride either. I'm going to tell you a little bit about dentistry really quickly. This is how cavities work. You eat some food, cariogenic is cavity. It ferments a carbohydrate and goes into biofilm. The biofilm is plaque. There's a rapid action of a pH decrease, which is more acidic, all right? So when that happens, that acid formation, it starts dissolving the crystal structures in the enamel, and then it demineralizes, and if the process doesn't stop, that's how you develop a cavity. Now, the cool thing about this is we call that demineralization. Taking enamel, the hardest structure that we have, you put in acid, it dissolves this crystal. The cool thing is we can remineralize. We can remineralize things. How do we remineralize it? By replacement of the ions that are being subtracted, right? So calcium, phosphate, and fluoride, when it's remineralized, is harder than before, okay? But it has to be done in a certain environment. So when it reforms a crystalline structure, it can become acid resistant. The problem is if you're missing multiple ions and you're only putting fluoride, but you don't have enough phosphate and you don't have enough calcium, which is in the good, healthy saliva, then you're not remineralizing. You're just adding more fluoride. So for this to work, the biofilm has to be neutral or controlled, and you do that by, it's like crabgrass. You just got to get rid of things. It's like a swimming pool or an aquarium. When a pH goes low, it gets really cloudy and gunky. You got to shock it. And you shock it and you grow a healthy biofilm. That's what we want to do. So this is the usual suspects, right? So the usual suspects is saliva contributes to about 63% whether you're going to get a cavity or not. This is called caries risk. The diet is about 50%, whether you get it or not. These don't add up to 100%, so don't do the math. It's just a factor. It's a factor. Now, bacteria, about 45 to 50%, the bacteria is in your mouth. There is a genetic component. There's some genes that carry this. It's about 40 to 55%. The last thing is 100% whether it's a determinant whether you have grow a cavity or not. And I'll tell you what that is tomorrow. No, it's the pH. It's the saliva. If your pH is neutral or above, it's very hard to grow a cavity. Okay? So that's why it's important about saliva. Yes.
Who's going to test this pH? Like, my dentist never offered pH on my saliva. So who tests that pH for you?
It's very simple. It's just litmus paper. The question was, who's going to test this pH because her dentist doesn't test for it, right? Well, that's what I'm trying to train people to do. You can ask them to test it. You can get pH paper, which is very cheap, and you can test it, but I'm going to get into that in just a little bit. So that's a great question. Couldn't have been better a plant right there. Okay, so the problem with medications that we give increase risk factors. You can't read all the medications, but there's 4 types of risk factors. The pink one, or the salmon color one, is a risk of stomatitis. The goldenrod is a risk for reflux. The blue is risk for xerostomia, and the green is a risk for caries, because a lot of medications have sugars in them. So if you can imagine a medication that has a side effect, and a lot of the medications that we're talking about this morning has a side effect, and you overlap them with more medications, no wonder your saliva is impaired. It impairs the buffering capacity of the acids. Does that make sense? You go, oh yeah, that makes great sense, right? So it's a balance, it's a tug of war, if you will. The tug of war, the disease indicators, that's what us as dentists are supposed to be looking at. They're called white spot lesions. When they dry the teeth and you see white spots, that means the teeth are demineralizing. It doesn't mean it's a cavity. It just means it's dissolving. So we have to look for the white spots. Have you had a filling in the last 3 years? If you had a filling in the last 3 years, you're more prone to more cavities because that tells us your bacteria is not really good, and we're telling your saliva is not great. Enamel lesions and cavities, we look at x-rays and we see those. In the middle are the risk factors. Those are things we can change. Do we have bad bacteria in our biofilm? The absence of saliva or destructive lifestyle habits. That would be, too much snacks, too bad of snacks. Snacks in themselves aren't really that bad. You just have to get them off your teeth afterwards, okay? So saliva should be water-like. So when you open your mouth at home and look in the mirror tonight, when you open your mouth, look on the floor of your mouth, it should have water on the floor of your mouth. If you don't see water, you might be a little bit dehydrated, okay? If you see your saliva bubbly, thick or stringy, or just lacking, that means that your saliva is not in good shape, okay? So back to the pH question you just asked about. The little litmus paper, you just test it with this resting saliva, and it'll tell you what pH is your resting saliva right now. It's kind of interesting. And if you were to do something like take baking soda, rinse it, mix it in water and rinse with it, your mouth will neutralize very quickly. How much baking soda? Not too much. 1/4 teaspoon in a glass, 1/2 teaspoon. Anything more than that's too salty. It's just disgusting. So the key is neutralizing it. They have sprays that will neutralize saliva too, and that's kind of important. So on the protective side, on the balance, if you look, the middle bar is the pH. Everything favors a destructive environment. So prevention says to go the other way. Improving your saliva, drinking more water. How many times are we so dehydrated, especially if you're geriatric or patients that you're taking care of, you don't get a lot of water. Why? I don't want to take them to the bathroom, right? So they're constantly dehydrated. Sealants are the great things. Sealants protect the grooves of the teeth. That's where a lot of bacteria love to hide. The byproduct of acid, like the backslide you saw, was acid. If I fill up the grooves with a sealant, then the acids don't stay in that groove and I don't get a cavity, right? But the sealants you want are the sealants that are called fluoride sealants. They're easier to place, but they continue to release fluoride, and they're anti-cariogenic. Anti-cariogenic means that it resists cavities. The antibacterials, sometimes you have to do a short course of antimicrobial called chlorhexidine. There's three antimicrobials: chlorhexidine, iodine, or sodium hypochlorite, which is a weak bleach. That's what kills the bad bacteria so that you can grow a good set of good bacteria. Fluoride, calcium, and phosphate need to replace that. There are some pastes for that. You can get some of this stuff out of your natural foods. So back to the first conversation about eating healthy. If you eat healthy, you'll have the calcium that you need. And if you need other things, they have some pastes called MI paste or nanohydroxyapatite. So let's see. Effective lifestyle habits, the good rest we're talking about, but keeping stuff off the teeth that are bad, and a risk-based assessment. The risk-based assessment basically is more frequent if you're higher risk, okay? So if you're to remineralize, I told you you need certain things. You need to have a salivary pH that's at least 7 or neutral, some form of fluoride or nanohydroxyapatite, biofilm control, calcium, and phosphate. And my friend Doug Young says this: it's like making a cookie. If your cookie had 5 ingredients, flour, egg, sugar, chocolate chips if you want, what other ingredient you want to have, vanilla, and you put it in the oven at whatever time, you'll come out with a cookie. Whether it tastes good or not, I don't know. But if you're missing one of the ingredients, it's going to be a mess. It won't work. Or if you don't turn on the oven, it won't work. What we've been doing is we've been telling you things, but you didn't know to turn on the oven, or you forgot a certain ingredient. And that's why we haven't been able to remineralize things. So we can test things through ATP testing also to see how active your bacteria is. This is a technology of bioluminescence that actually NASA used to test for bacteria, and they use this in food service as well. They take ATP and luciferin. When it's bound together, it creates a little light. You can't really see it, but it's a little light meter that sort of is our surrogate marker to see how active bacteria is. And so we'll test a blood plaque to see how active bacteria is. We'll get them on a course of antibacterials, and we'll have them come back and see how well the change has been. Another thing that's kind of cool, saliva is where it's at. Salivary diagnostic is really kind of a cool technology now. A lot of particles are in saliva that we can figure out things with. They have this oral genome test kit where if we collect a little saliva, we can put it in a little tube, and through a picture, through a camera, in 15 minutes, I can tell you the risk factors of cavity risk, gum risk, diabetes or prediabetes. I can tell you a little bit about the nitric acid that's in this gum area and their health. And these are kind of the tools that we have to start utilizing if we're going to be prevention oriented. Now, I couldn't do this at dental school because it costs money. Where I am, we're doing pilot studies so we can gather some data. That's why I had to leave to grow and learn more. All right. So these are kind of cool things in technology. Salivary diagnosis is also being used for detecting cancers because there's cancer cells in saliva too. David Wong down at UCLA and a few other, no relation. He's smart and I'm not as smart, but he's got some great salivary diagnostic tools that's handheld, similar to the ATP meter I showed you, that if you can use that to diagnose things, we can look at prevention at a different scale, right? So talking about prevention, so how do we change things? When I kind of combined prevention with working Special Olympics and teaching at the dental school, my colleagues over there, Desmond Ng, Dr. Ng's over there, we sort of create these clinics, if you will, called SODA, Special Olympic Dental Academy. And we utilize that for a couple of reasons, for feedback. Right now, the way dental communication is this: the dentist tells a patient things and tells a caregiver certain things. What we really want to do is we want feedback. We want feedback from the one that's getting the care and the caregiver to feedback to us what's working, what's not working, and how do we modify it. Bless you. Bless you. Okay. All right. So we need to redefine how we educate in dental education, because that's a key to everything. I can tell you floss and brush, a little bit joke about the rats, the mice flossing, but that's kind of where we are. If you're telling someone something and they're not able to succeed, then we're not able to do this properly. So we have to find ways, how do we do things better? So what we do is we have the athletes and those come in, we give them a little bit of information, and we ask them, do you understand that? Or how would I say that differently? So getting feedback from the people we're giving care to makes a lot of sense. And then we also talk to them about simple lectures, even medical immobilization. So our athletes will immobilize our students, our dental students, and our students will immobilize them. And when you take away the fear of things and they understand why you do it, if you seek to understand and then be understood, a lot of things can happen that are kind of magical. All of a sudden, we're having fun, we're laughing, we're learning. And importantly, the future practitioner will feel more comfortable taking care of this population, right? So not all is bad. So telling them what we're doing, showing that what we're going to use is very helpful. But more importantly, the dental student has to hear from the patient how it made them feel and what we should be saying. And it breaks down this communication barrier. We'll have some small group interviews. We'll chat with the patient along with the dental students and sort of build a community of yes, we can. Small discussions, demonstrations, so that we're not frightening people. One-on-one hygiene mentorship show us what you're doing. Let us show you some tricks on how we can do a better attitude instead of, oh, you're not brushing long enough. You're not flossing enough, right? In Special Olympics, they have this oath. It's let me win, but if I cannot win, let me be brave in the attempt. That's a noble thought. All Special Olympic athletes do that. My thought to all practitioners is, let me treat, but if I cannot treat, let me be brave in the attempt. We got to change cutting the pizza all one equal size. We've got to make sure that the size is appropriate for the eater. Make sense? So instead of having an hour and a half an appointment, let's not make it an hour and a half. Let's make it time that the patient can accept and handle. We want that done for us. So what's the applications? Hopefully, the application is in academia, that we learn, teach our professionals how to do better desensitization techniques, utilize standardized patient models instead of actors, use actual participants who want to be, to give the authentic feel and feedback that we need to have, and a patient-centered curriculum that fits their need. And hopefully, private practice, we can learn from that. We've got to have practitioners sensitized, desensitized, learning about this, and then incentivize them by learning and doing it properly with a prevention focus that they can be reimbursed at a higher level. That's the only way this is going to change, because if it's going to take more time, you should be compensated for that. Unfortunately, in California, we have a new 9920 code that allows us to bill for a little bit more time for things that take more time. That makes sense, right? Retraction and seeing what you want to do is very important, but it's very scary to have someone pull on your cheek. So I worked with this company to develop, and I have no monetary thing, but it's a very bendable, very flexible, very soft appliance to help retract the cheek and the tongue. But we use this as it looks like a toothbrush handle, but we give it to the patient so they can be familiar with it. So when they come to my chair, that they are retracting and I can see. But more importantly, at home, the parent can retract the cheek and brush and see better, because if you ever tried brushing teeth for someone else, it's not fun. Go ahead and have your spouse try to brush your teeth tonight. You're not going to like it. You're not going to like it. But anyway, so what I say is it's almost like brushing your teeth in the dark. It's not that easy to make sure you got things. So if I can give a tool to someone, and I was hoping to bring some with me and I forgot, I apologize. But it's very useful to see what you're doing and do it gently. So this is a little tool that we had. So other tools for success, I don't care what toothbrush you use. They all work. What's important is, what does the patient want to use? All right, so whether it's a Sonicare, Oral-B battery, they all work. I have a little preference, because I sort of disclosed before that the hum brush is very gentle, and it's kind of, to me, therapeutic. It hums. But there's two versions. They both have a Bluetooth capability for the phone, so it's gamified if they want to use, and kids like it, right? So whatever. Okay, so if you gamify something, they'll do it, you know? So you have to go to where they're at, and they get rewarded certain things. There's a new one that's sort of a full arch, sort of vibrating one. Doesn't fit our population very well, because the maxilla is small and the tongue is large, so it doesn't fit a normal arch. It doesn't fit a disparate arch very easily. But anyway, whatever's good. Other tools that are helpful, if you can't floss, there's floss holders, there's floss picks, there's tongue scrapers, there's water picks. If you can't find a tongue scraper, you can use the back of a spoon. That's okay too. But there's a lot of bacteria on the tongue. So it's one of those things that it's not a revolution, it's an evolution. You introduce things slowly, whatever they can tolerate, however they can tolerate. So back to Special Olympics. We gathered all this information and data, and we convened with the Surgeon General about 20 years ago and realized the disparity of healthcare. So they said that we're not going to fix this solution in silos. We have to work together. So we created the American Academy of Developmental Medicine and Dentistry, And we partnered with the National Council on Disability to help improve access to care and bring up this importance of disparity of care in education. We were able to change the code of ethics to the American Dental Association to include disability because it was overlooked. And with that, we were able to create change in the Commission on Dental Accreditation standards. So every student after about 2022 has now got to be trained to not only assess, but also manage patients with disabilities and those with intellectual and developmental disabilities. So every dental student now is mandated to hopefully do that before they graduate, right? AADMD also has a similar program for medical schools that we're encouraging medical curriculum to be developed, and we have about 30 medical schools on board with that. And so we're looking forward to making a change in healthcare for populations with intellectual developmental disabilities. The change that we had right here in the predoctoral standards is and managing, because back then you could see it and refer it. Now you have to manage it appropriately. So the problem whenever you sort of mandate something is what's going to be taught, who's going to teach it, what's going to be used as a curriculum. And a lot of times dental schools say, we don't have the faculty and we don't have the curriculum to put this in because we already have too much already. So AADMD tried to answer that question. So my school, University of the Pacific, University of Texas, and Penn Dental got together, and we have 93 authors working on this pilot project that is almost ready. We're rolling it out this fall to give to the dental schools and dental hygiene schools and dental assisting schools to teach the curriculum that's necessary. And it's made in a fashion that is beautiful, because the problem with medical and dental education, when we teach things that are different, it's kind of scary. If you ever look at a textbook on someone, you see someone either naked or someone side profiled with their eyes blacked out. And this curriculum doesn't do that at all. We celebrate the differences. And some beautiful pictures from a photographer called Rick Gadati. If you've ever seen any of his work, he's wonderful. But he features people in the light that they should be featured. So we're very proud of it. The curriculum is going to be online and downloadable so we can update things. So the students will be able to download it. Faculty will be able to download that plus a PowerPoint that they can teach with. And it's going to be rolled out soon. We have self-advocates are going through it to make sure that we're appropriate. And so we're very excited by that. And here's some resources here. I'm going to stop at this point for any questions. And if you have a question, we'll hand a mic to someone.
Hi.
Hi.
Again, very enlightening, just incredible. So there isn't, you're saying that students are now going to be required, but they haven't yet. So in other words, like this curriculum, you're developing it, and it still has yet to be taught at the dental schools, correct?
Yes and no. Some dental schools already have some curriculum already. This was made for schools that don't have a curriculum, so there's no excuses. Fortunately, University of the Pacific has already been on top of the game, so we have the curriculum, and we also have a special care clinic that gives our graduates the experience. But a lot of dental schools are starting to develop that now, but they have 7 years to implement everything. So everyone is moving towards that curriculum. They don't have to use ours. It's just there in case they don't have one, so there's no excuse that we don't have something to teach.
And then just a follow-up. And so what's going to happen with the dentists who are practicing already? Will there be some sort of expectation that they go back and learn to, work with patients with developmental disabilities?
Well, that's exactly right. You'd hope that they do the right thing. So we have more and more continuing education courses for the ongoing practitioners to take if they want. But that's our goal and our hope. And like I said earlier, if we can incentivize them to get paid at a higher level if they take these courses, then we'll have more competent professional crew out there. Let me say one thing before I get further. The most important people are you here in the room, because I told you that our journey leads us to different things. So all of you probably have a dentist. So all of you need to ask them, do you see people with intellectual developmental disability? And hopefully they say yes. But if they say no, you need to let them know there's training for that. So in a loving fashion, you need a grassroots effort to make sure that we're consistent, because your family members should not have to travel 2-3 hours to get care. So you are very important to sort of gently nudge them. And each time you go in, you ask them, oh, have you taken any classes? Have you taken any courses? But I think the only way things are going to change is if partly they know that there are courses out there, but they have to change their way of thinking. This is not acceptable that you're not seeing patients. It's not acceptable that you're not learning new information. Question?
Yep, I got a quick question. With the increased prevalence of periodontal disease in people with Down syndrome, do we know anything about the oral microbiome? Are there differences there between neurotypical and people with Down syndrome?
Yeah, exactly. That's a very good question about the oral biome. There are differences. We have not been able to research the exact amount of differences and in what areas as of yet, but that's where we're looking towards, because we have, just like you, we have to enroll studies and be able to do that intentionally. But I believe there are some. We already know that they have risk factors that are different and challenging. And so, yeah, the good question. We need to do more research in that area.
We've been fortunate to find a dentist that does treat a lot of kids with special needs, and have followed him once he left our town, followed him a few cities over, and he's recommended going every 3 months for a cleaning. So we've been doing that, but only 2 of those cleanings are going to be covered by insurance each year. Is there something that we can do to talk to insurance to see if it's possibility to get more coverage, or is that something that's just in progress with different insurance companies? Or not at all?
That's an excellent question. It's something we should all be doing. When I do and ask insurance for more payment, more things, it's always because I'm the rich dentist and I want more money. When you do it, it's because it's important. So we have to embrace the change in all categories. But the science is what's important. The population that's at greater risk needs to be seen more frequently. We have to go back to that, like instead of, well, everyone's equal, everyone gets 1 cleaning a year, or everyone gets 2 cleanings a year. That's not equal. We want equity. Equity is health. Health equity means if you need to be seen more frequently, you're treated more frequently. If you had hypertension, and I had hypertension, my hypertension is probably more severe than anyone else's, I should be seen more frequently, monitored more frequently, and treated more aggressively until I am, quote unquote, in a safe area. We're not doing that in dentistry. That's what we need to start doing.
So I believe there's some studies that correlate missing teeth with dementia. Is there any information out there with people with Down syndrome and their dental anomalies and dementia?
Oh, very good. That was a study that's not too recent. I mean, it was fairly recent, actually. Yeah, there are some correlation studies of more missing teeth and dementia, but there's also a correlation that if there are more dentists per capita, there's more teeth that are removed. That's not a good sight for us dentists, you know. But I think what happens is sometimes the implicit bias, if you will, is if we see something bad, it ends up coming out because insurance doesn't pay for it. So there's a little callousness about that. So I don't know exactly, but I agree with the study that there are some risk factors that contribute towards early tooth loss. But, you know, we don't have a control study saying that if we saw the patient more frequently, would that not been a tooth loss?
Can I just add on to what she just said? Because my son has lost all his teeth down here, and he has osteoporosis very badly, because osteoporosis is -2.5, and Greg, my son, was -4. And he fell and broke his hip, and then, you know, the teeth are gone. And so I don't think it had to do with the study, but
Could be a lot of risk factors. It could be the shorter roots.
think it was.
Could be the shorter routes, could be a lot of medications deplete the calciums also, especially the seizure medications can do that. So, there's a lot of, it's a multifactorial thing, so I can't say it's one thing, it's probably a combination of different things. But, yeah. And if there's trauma, if he fell on the smaller teeth, they loosen up also.
Okay, thank you, Alan. That was
Okay, I'll
wonderful.
stick around if you have a question, okay? Thank you very much, everyone.